Okay, good afternoon. Welcome to this afternoon's meeting of the Adults and Communities Overview and Scrutiny Committee. Can we first move to agenda item 1, which is the appointment of chairman, and this is to note that Mr Richardson was nominated as chairman-elect at the meeting of the County Council on the 15th of May 2019. Can I ask that everyone is in agreement with this nomination?
Yeah, I'll move that.
Okay, so Mr Richardson.
I was hopeful that Gemma was going to do the whole meeting, but she refused. If I could just welcome everybody to today's meeting of the Adults and Communities Overview and Scrutiny Committee. If I could just remind everyone present, this meeting will be broadcast live via the County Council's website and will also be available for viewing after the meeting. When you do speak, can you please switch on your microphone and please remember to switch it off when you finish speaking. I've received apologies from Dr Bremner, with Mr Gillard acting as his substitute. And I think we've got apologies from Mr Mio, if we shall.
Yes, I'm substituting for Jewel Meir today.
Thank you for that. Agenda item 2 is election of Deputy Chairman. I'd like to propose Bill Lickerish.
I'd like to second that, please, Chair.
All those in favour? Thank you. Right, we now move on to agenda item 3, minutes of the meeting held on the 11th of March. Do I propose her? Seconder? Thank you. All in favour? Agreed. Right, it's agenda item 4, question time. We have received no questions from members of the public. Agenda item 5, questions asked by members under Standing Order 7.3 and 7.5. We do have a question from a member, but we're going to take it under agenda item 11 as the member is present, and I've worked out through our Democratic Service Officer that that member wants to ask supplementary, so we will invite them to the table at the appropriate time, if that's agreeable to members. Agenda item 5, questions asked by members understanding. Oh, sorry, I've done that one. Agenda item 6, to advise any other items which the Chairman has decided to take as urgent. I've received no urgent items. Declarations of interest. Do I have any declarations of interest from members in respect to the agenda items? Thank you very much. We have no declarations of the party whip, and we have no petitions under Standing Order 39 under agenda item 9. So we can start off on the substantive agenda. So we're starting off on agenda item 10, which is pages 13 to 20, and is on the subject that we just had the briefing on, which is the Adult Social Care Target Operating Model, which must be with you, John.
Thank you, Chair. So as committee are aware, we undertook a diagnostic assessment in July, August last year to determine how the social care operating model could be improved and how we could improve outcomes for our service users and carers, whilst at the same time ensuring that we were as efficient as we could be as a county council. Following the diagnostic assessment in November, Cabinet approved the work to take forward the design and implementation of a new operating model based on the outcomes of that diagnostic assessment. And on page 15 of the report, we detail the key areas of work that are being taken forward as part of the design and implementation of the operating model. So those are specifically around our reablement offer, around our decision making, particularly in respect to residential placements, both for older and younger adults, how we could improve the quality of the service, and how we could develop an enablement service for working age adults. And on page 16 there is a summary table which provides the expected outcome in terms of financial benefit for the council as we do that work. So the work takes place in 2 phases. There's a design phase from March to July of this year, and an implementation phase from July through to next year. Key activities that take place during the design phase are that we identify where we think we can make improvements to the service, we trial and test new ideas, and then following that trialling and testing, we agree those areas that we think we can take forward to improve the model of service. And then as we get into implementation, we roll out those ideas across the county, locality by locality, or service by service, depending on the particular area of service that's under consideration. So at the bottom of page 17, there are some indications of the sorts of ideas that we've begun to test and the approaches that we're taking. And we'll take those forward as we go into, over the next 2 months, we'll be seeking to sign off those ideas as being the ideas that will be implemented across the county. In terms of how we seek to roll that out, it will be a combination of rolling out, so for example, the reablement service, which is a county-wide service. We roll that out. We've already tested the ideas in Hinckley. We've begun to see the improvements that can be made. We're now moving on to Bassett Street office to further test those ideas, and once significant progress is made there, we'll move on to our next office, etc., etc. In terms of the older adult services, we're testing the services and the redesign of services in North West Leicestershire as our starting point, as our trial site. And again, once we've been through North West Leicestershire, we'll then move on to another locality. Working age adults, we're testing in the offices in Wigston. And again, we'll then implement those fully in Wigston and then move on to another locality. So, and we'll just roll out over the next 12 months in that way. The financial benefit, as we've said, is somewhere we think between 10 million and 13 million. There is within that financial benefit a quality improvement, so we're not expecting to have a fully cashable savings of that nature. There will be a reduction in terms of the cashable saving, which will be our quality improvement area. So rather than take it, for example, if we were saying that we could undertake more assessments with fewer staff, we wouldn't reduce the number of staff. We'd just take those staff and we'd ask them to do more reviews, for example. I think that's probably all I need to say at this point. Thank you, Chair.
Thanks, John. Mr. Sheehan.
Yeah, there's a sort of programme unfolding of testing, rolling out, etc., etc. Can you tell us what you've learnt so far, or alternatively, is there any practical experience of this new operating model elsewhere?
So in terms of what we've learnt so far, so one of the areas that we're looking at is the customer service centre. So how does the customer service centre operate, and how can we improve the time it takes for work to take place and move through the customer service centre and be passed on to the localities. So referral comes in, it's taken by the customer service centre, they do an initial contact assessment, they'll then do further fact finding, they'll contact other agencies and they'll try and ascertain whether or not the person requires a service. If they think the person does require a service, they'll pass that on to the locality, and the locality will take a full assessment. At the baseline, when we started to do this work, it was taking just short of 8 days for that initial piece of work through the customer service centre to take place. We're now down to 2 days. So there's an immediate improvement there in terms of, if, for example, it's taking on average 30 days for a person from referral through to assessment, the first 8 of those days were in the customer service centre. We've now reduced that to 2 days. So that immediately brings forward that timescale. And it's quite important to people in terms of outcomes that they get their assessment as quickly as possible, clearly. In terms of the localities, in the reablement offer, for example, as I said, we've started to test in Hinckley. What we found in Hinckley is that we can improve the productivity of the reablement service by changing some of the decision making, so bringing some of the decision making forward within that process, by ensuring that we review on a daily basis rather than a weekly basis. And that means that we can free up capacity in the reablement service such that we've managed to already take on all the work of the independent sector in the Hinckley and Bosworth area and bring it back in-house into the Heart Service. And we anticipate doing exactly the same when we move into the Wigston area. So we're already seeing some improvements taking place. We know that some of the models that we're looking at have been tested and trialled and implemented in other areas, in other authorities. Our ailment service a couple of weeks ago went down to Swindon, which is an area that have been through this process previously a couple of years ago. So they've made contacts with colleagues in Swindon and they're sharing their experience of the implementation. So we're making those kind of links as well.
Thank you, John. We're now going to Michael Smith. For newer members to the committee, just before Michael comes in, Michael is from Health Watch and has a standing invite to the committee. So, Michael.
Thank you, Chair. Take it round with me. I'm just curious as to, during the design phase, how you've been involved in kind of getting the service user kind of perspective on what the changes may be and how that's going to impact on service users kind of going forward.
Yes, it's an interesting area in terms of involvement, because clearly, as it's part of design and we're only testing and trialling, we don't necessarily want to give people false expectation. That's the first thing. But it is important that we also get the views of the people who are using the services as part of that process. We have a process that we use with staff, sort of checking mechanism with staff and dip testing. So checking people's opinions, checking how people feel, checking how the work's going from a staff perspective, and we're beginning to also do that now with service users. So it's a sort of a random sampling, if you like. I think one of the things that, if you think about the short-term interventions such as reablement, it's easier in those services to be able to check satisfaction at the beginning and at the end point, because there is a beginning and an end within a very short space of time. When you're working with people with, for example, learning disabilities, and you're thinking about long-term moves into supported accommodation and sort of more independent accommodation, that's obviously a much more difficult process. But of course, one of the areas that we can improve is the matching process. So what we mean by that is when we have a service user and a family who've identified that somebody wants to become more independent and live more independently, we then have to consider that person and where they can live and who they can live with. So we have to match that person against a suitable property, and we have to match that person potentially against somebody else who they may be living or sharing a building with. And we've made significant improvement in the way we do that, and we've speeded up that process, which was taking a very long time and was a source of frustration for a number of people. And we've involved people in the way that we do that. We also have consulted with people like the Learning Disability Partnership Board. So we've been going through the normal forums that you'd expect us to go through and talking to people about what their experience has been and what they would want to see.
Mrs. Fryer.
Thank you very much. The question or the clarification I would like is on page 18, paragraph 20. It's to do with the finances of this, and it does say that should the programme not deliver a recurrent annualised benefit greater than 1.5 times the one-off fee, their fee will be reduced. Now that is fine, but what I wouldn't like to, or I'd like some reassurance that so that they are not out of pocket, they're not going to penalise the work they're going to do to ensure they're going to. So yes, they've made the saving, but at what expense, if any, to the resident? And I'd just like some more clarification, if possible, how that will be scrutinised and matched. I presume it will come back to us. There will be targets. There will be things that will come back. There will be proof that not only has that finance side been matched, but also the service side has been assured. Thank you, Mr. Chairman.
Okay, so this is quite a complicated process, as you can imagine. So as part of the overall governance of the programme, we have a meeting every month called the Benefits Monitoring Board, where we sit down with colleagues and we agree what's been achieved within that particular last monthly period. We set off with a number of baselines. So we baseline the activity, we baseline the finance, and then on a monthly basis we measure improvement against those baselines. And we have two measures. We have a bottom-up measure, which is the individual service user outcomes. So we look at them as individual outcomes on a case-by-case basis. And then we have a top-down measure, which is the overall benefit to the service and to the service area. So we can measure on an individual basis how much improvement is being made for each individual person, and we can measure the overall benefit for the service and for the council coming at a strategic budget level, if you like. And before we sign off any invoices for payment of the fee, we agree whether or not the targets have been made in terms of the improvements. And if the improvements haven't been made, then we don't sign off the invoicing, or we reduce the invoicing levels. Now, the way that the 1.5 times the one-off fee works, it's a contingency basis. So it makes the fee contingent on the delivery of the outcome. But it's contingent on the delivery, because it's a financial, this part of the contract is a financial process. So the fee is contingent on the delivery of the financial benefit rather than the service benefit. But clearly, if we didn't think that the service benefit was also being achieved, we wouldn't be signing off the invoicing.
Mrs. Wright.
Oh, it's working now. It's just a general question, really, and to how do the design phases fit into the national picture and the initiatives? So really, whatever comes in the pipeline, because we hear about the national crisis in care, it's just what flexibility and adaptation have we got in there to adjust to anything that may come down the line?
I suppose the design phase itself isn't particularly linked to sort of changes in national policy or legislation. It's a fairly short period of time, so we're only talking about 2 or 3 months worth of work as part of the design phase. Now, obviously, within the contract that we've drawn up and the specifications that we've drawn up, we have made provision within there that if there were a substantial national policy or other change, then we would have to renegotiate and rethink through the contract. I suppose we're working towards what we think is national best practice. So unless there are any significant changes, we anticipate that the benefits that we will be drawing down will be consistent with current legislation and policy. But should there be a significant change, then obviously we would have to renegotiate and rethink the programme.
Right, in the advent of no further questions, I would just comment really that to me the most important part about this whole document was paragraph 16 on the bottom page 17. And I for one would like to have seen it in bold. I think it states, and it's worth reading out, this approach being adopted is not about cutting services, but placing the best and most independent outcome for the service user. And I think it's really heartening when we have a document that actually commits to that in it. And I think it's a testament to this council. And I for one, would almost like to see that be in the first paragraph in big bold letters 6 foot high, because I think sometimes these get missed by the public who just think about us as trying to cut costs. And the other thing that occurred to me is that were we to achieve the greater face-to-face time for our practitioners we're searching for, the actual more job satisfaction they would have as well is not highlighted in this report, and that to me is a crucial one, that this makes it better for our staff as well, who will do the things they really want to do as opposed to filling in forms. So I think we note the report, and I'm sure that members would like to have regular updates on where we're going with the target operating model going forward. We now move on to agenda item 11, which is an update on North West Leicestershire site development. And if I could invite Terry Inan to join us at the table, rather than you come up to ask your question at the end, you might as well sit here for the whole report. And then we're back with you, John.
Thank you, Chair. So the report today is partly an update for the committee on the progress that we're making with the redevelopment of the site in North West Leicestershire, but also an opportunity to seek committee's comments ahead of a cabinet report, which will be presented later this month. Committee will recall that in June last year, Cabinet agreed to redevelop the site at Smith Crescent in Colville, and then in February, £3.7 million was allocated for that redevelopment within the Council's capital programme. Committee will recall that the particular elements that we're talking about are the Hamilton Court Residential Care Home, the Smith Crescent Short Breaks Unit, and 2 supported living services, which are all on the same site. The plans for redevelopment are outlined in paragraph 6 on page 22, and subject to cabinet approval later this month, we'll be seeking to develop up to 16 self-contained supported living properties, a new 6-bed short breaks service, and suitable space and facilities to provide the community life choices which are currently provided at the Colville Resource Centre. Subject to the necessary consents, phase 1 of that development would include the demolition of the existing supported living services and the Hamilton Court Residential Care Home, together with the build of the new short breaks facility and one half of the supported living flats. And then phase 2 would be the demolition of the existing short breaks facility at Smith Crescent, the development of the Community Life Choices service, and the remaining supported living services. I also want to note that there has been a significant amount of work undertaken to make sure that people who are using those services, their relatives, carers and independent advocates have been involved in the process, both in terms of thinking about what the future accommodation services and future services would need to look like, but also individual conversations with people who are affected by the changes. The 2 remaining residents at Hamilton Court are expected to move to their new services by the end of July of this year, and we have worked with local housing associations and with local district and borough councils to try to support the existing supported living tenants to find new accommodations, although we have also suggested that should they wish to, when the new services are developed, they would have first refusal on one of the new properties. There is a high-level timeline, paragraph 15, in terms of the governance and developments, and then we have just given you some ideas of the sort of design principles that we're working to in terms of the service delivery and design. Thank you, Chair.
Thank you, John. Now, members will note there's been a written question from Dr. Inan and the response, which has been circulated to all members, but I understand that Dr. Inan would like to ask a further question.
Yes, well, thank you. The question as written, and I'm very pleased with the reply, but I just wanted some clarification, because as I understand, individuals and carers have been advised of the plans for the Colville Resource Centre, and I guess in the context of the much bigger piece of work you've had to do over the Smith's Crescent, which I'm very satisfied with, then perhaps this is not something that I'm not sure that I was aware that this was going on until today. So as a local member, I would have liked to have known, because I had rumours in my community that they're going to close the resource centre. I'm going, you what? No one told me. Now and I'm pleased that there will be access then to community, that we're going to support more people to have access to community local facilities. And I think this is an issue in Colville, is that the resource centre has always been badly placed. I think that is well known. It's on an industrial site just outside the town centre. It doesn't feel like it's part of the community facilities, which are mostly co-located in the town centre. So what I'm interested to understand in preparation for this, which I'm sincerely hoping gets through Cabinet without any trouble, and I'm sure it will, will we be working with the third sector and the other community resources in the town centre so that this isn't a shock to the community, so that there isn't any gap. And the other question was, and perhaps we can't answer this now, but more a question I'm asking to have it on the table, if in due course we find that the resource centre is surplus to requirements, how are we going to think about reinvesting the capital? Because there in the town centre there are community facilities and third sector facilities which we would probably want to make better use of, and could any capital receipt from that be ring-fenced for that kind of work?
Okay, I'll try and answer those questions. So the first one is just to apologise in terms of local member information. Clearly, we haven't been as open and transparent as perhaps we should have been. So I apologise for that, and we'll try and address that in future. In terms of the service itself, we do have this model operating in other areas of the county. So at our other short break services at Melton, for example, and at Carlton Drive, we have a combined offer where we have day services and short breaks, and it works particularly well in terms of the ability of the service to be able to run multiple services on a single site. It's much more efficient and more effective from a service delivery perspective, but it also works quite well for people who are using the services, because actually quite a lot of them use more than one service. And it's the same staff group, so they get to know the people who are both in the community life choices and in the short break services. We haven't had quite this level of supported living on the same site, so that's something that will be new and that we will have to think about carefully in terms of separation of services. The way that we anticipate the service working is that there will be much more provision of community-based activities rather than centre-based activities. And you're right, the Colville Resource Centre is not the most ideal building or the most ideal location. We don't use all of it now. We anticipate using less of it in the future. What happens to that particular resource will effectively be a decision that's taken not by the Adults and Communities Department, but by the Council through its property services functions. I anticipate that if it is deemed surplus to requirements, and if there is a capital receipt, I would have anticipated that capital receipt would probably go to offset the build cost of potentially the 3.7 million. But in addition to that, and there are further reports on today's agenda which also highlight that we are seeking to make further developments in North West Leicestershire. Potentially a dementia support service and possibly some extra care. So I think overall the investment in North West Leicestershire will probably be quite substantial over the next few years.
No, you look like you were poised, Richard. Right, so I think we note the contents of agenda item 11. I think members are supportive for this, and I know it's been through this committee several times, and let's just get the thing built, I think is the answer. So we now move on to agenda item 12, which is developing sustainable health and social care, which is pages 31 to 38. And I think you've got everything today, John, so just keep going.
I'm just going to do a very short introduction, thank you, Chair. This is an update for committee. I think committee asked last year for an update in where we were getting to with sort of the integration of health and social care services. So this is a report which details some of the elements of that integration programme, and I'm going to hand over now to Peter, who's leading that programme, to run through the rest of the report.
Thank you, Chair and committee. I'll briefly just give a synopsis of the report. And the topics covered in this report are actually a subset of a much larger programme of work to transform health and social care across not just Leicestershire, but the Leicestershire, Rutland and Leicester City footprint. This report will focus on three areas. The integrated discharge team, Home First and integrated locality working. So strategically, the vision is that an enhanced and extended Help to Live at Home framework will work more closely with refocused heart services which are our own internal services, and this is integrated with health services working at both step up and step down within the IDT service, the integrated discharge service based at University Hospital Leicester, and linked into the developing integrated locality teams. So you have a golden thread leading from the wards right through to place and the localities. This means there is a need for new models of working and service delivery across health and social care, and there is a legal imperative set out in both the Care Act and the NHS long-term plan. So focusing on our adult social care integration activity, page 33 refers to the examples of integrated locality teams. So what do we mean by integrated locality team working? The work in those teams will be centred around GP practices, based with other key professionals working to support patients and our customers in those localities. The focus of the work will be based on risk stratification, on managing need and working with patients who are at the highest degrees of frailty. There will be evidence of care coordination between professionals, with adult social care playing a key role in that care coordination. And at the heart of this will be enhanced multidisciplinary team working within primary care. And obviously the role of primary care is pivotal in that it brings together the links across complex healthcare systems and also the links within the community, ensuring also that there is a strong contribution from the County Council within this place-based activity, and that we, within the County Council, can contribute our considerable commissioning and procurement experience and skills into place development. So across LLR, there are 3 implementation sites, City, Rutland, and also in Hinckley and Bosworth, which focuses on a population of 45,000 people. There we're using local area coordinators. We also have a contribution from adult social care. We're seeing early development of those outcomes, working with increasing complexity, complex patients, very much strong partnership working with health and social care. And I think it's at early stage, but we'll start to industrialise that process. But separate to the early implementation site, the report also sets out that we have a well-based long-term tradition of working with GP practices across our locality teams. So already within the county, this is established model of close partnership working with GP practices. The Home First offer is described at page 35, and the aim here is to bring together health and social care resources, our own home care service, our crisis response service, and integrate that with the health integrated community care service, and in particular therapy services. And work is well underway into bringing these services together and also establishing a single point of referral as set out at paragraph 19, page 35. The impact on patients will be an improved patient journey, streamlined assessment, and better use of local resources at the level of place. And then finally, paragraph 20, page 35, describes the integrated discharge team offer. This is a team established at the UHL hospital, and the aim is to create a single integrated discharge service consisting of social care and health professionals who actively facilitate safe and timely discharges from hospital by reaching into wards and facilitating discharges. IDT will be linked both to locality teams and into GP practices. And the IDT is based at the hub office within the UHL. And all of this activity is happening whilst at the same time we are working with a strategic partner to improve our assessment and the timeliness of our interventions. And that's the report to committee chair.
Thank you, Peter. Mrs. Fryer.
Thank you very much, Chairman. Could I draw attention to page 32, starting at bullet point C? I'm being a bit facetious here because I am presuming the 2 million more people is across England and not just Leicestershire. But taking it on from that, do we have a county projection for that period as well? And also moving further down under D, the funding gap is about 1.44 billion. Against that, I presume, is across England and not just I should hope it's not Leicestershire, which it isn't. And do we sort of roughly whereabouts are we on that? Thank you very much. But mainly I want to know is what our projection figures are more likely to be, rather than just looking at it across the whole country.
Shall I kick off? The projection figures in paragraph D, we in terms of our commissioning activity and the care pathway response to that, that's based on public health commissioning forecasts, and with a degree of accuracy we are basing the development of our services on that. There are a number of paradoxes here because there isn't an absolute or definition of unmet need or relative need. As you see in the report, there are various perspectives. But that's how we would base our projections going forward, on what public health are producing in terms of demand, changes in demography, pressures, movements within the county.
Yes, just to add, so the projections for Leicestershire are contained within the Joint Strategic Needs Assessment, which was updated earlier this year. So those are fairly up-to-date projections, and they're available on the Council's website, and we can provide a link if that's helpful. In terms of the funding gap, so the figures quoted there are the national figures. They come from the Local Government Association and others who do an amount of work to collate and collect the amount of unmet need or undermet need, and that in itself is a conversation we might have later on in committee. But when we did some work around the LGA's Green Paper last year, and we looked at the cost of providing care to everybody that was contained within that document, it outlined that if Leicestershire was to meet all of that need, it would cost about another £90 million.
Mr. Sheehan.
Looking at paragraph 24 on page 36, this issue about access to the IDT, I'm not quite sure what the problem is and how big a problem it is, and more importantly, what you're proposing to do to resolve it, if indeed there is a problem.
Yes, Chair. This relates to licences and the issue of licences to our staff, and it's something that we're working on currently to make sure that there's a uniform access to those licences to allow access to systems and across. This has been an age-old issue between health and social care, not unusual, but we are actively taking steps to address that point.
Okay, so I suppose the question to follow that up with is, do you envisage being able to get this sorted out? I'd like some reassurance on that.
Yes, we will be getting it sorted out.
Mr. Smith.
Thank you, Chair. It's just really wanted to offer comment on having been involved in quite a lot of this process for quite a while now, just seeing the kind of engagement and the way that the public have been kind of brought into the discussion and the way this has kind of taken shape. So I just really wanted to say that from my perspective, it's just so reassuring to kind of be a part of a process when you can see that kind of involvement and that engagement from the beginning and carry on through.
Right, so no further questions? Right, again, we'll note the contents of the report, and I'm sure this is one that will come back many more times over the coming years, because being serious, it is important that we understand what the potential impact on this council is and what need we might have to meet going forward. So thank you, Peter. We now move on to agenda item 13, which is capital investment into adult social care accommodation-based support services, and is pages 39 to 110. And on the basis John is pointing to his right, we must be going straight to Sandy.
Thank you, Chair. Earlier this year in March, the committee received a report on the capital investment plan following a period of market engagement. And this report gives more detail to the committee on the needs analysis and how the council proposes to meet the shortfall in future supply of accommodation. It provides a detailed breakdown at district and borough level of the projected levels of need in each district and borough, and what our projections are in relation to the planned supply that will be available in each district and borough. And there has indeed been a great deal of consultation and discussion with all the district and borough councils about that needs analysis, and officers certainly there are familiar with that analysis and have had input into it. The report, there will be a further report going to Cabinet later this month, outlining the overall proposed framework for taking forward future developments over an extended period. So we're looking at an investment programme that could be for a period of up to about 20 years. So the overall framework for that will be going to Cabinet. And as part of that, really want to note that gifts of land will be a significant part of that going forward. And again, that's formed part of the discussions which have taken place with district and boroughs and other owners of land in Leicestershire. There are also a range of phase 1 developments which are underway, so we're very keen that we're not waiting for all the longer term solutions to develop accommodation, because accommodation is very much needed now. So there are a number of schemes which are detailed within the report which are currently underway. And Cabinet will in due course be receiving individual business cases as they relate to new larger scale developments, which will each have their own business case and financial case, which will be taken to Cabinet as each of those becomes ready. Thank you.
Looks like you stunned everybody into silence. So I can ask my question. Page 52, and I think it's also on page 50. I don't know whether it's the colours, but Harborough doesn't seem to have any line at all on the graphs, and there only seem to be, certainly on page 52, dementia, there only seem to be 5 councils I can identify rather than 7. So is there no dementia in Harborough?
I'm sure Harborough isn't exempt from people having dementia. I suspect the Harborough issues, it looks like it's a colour printing issue. I'm sure there is a line for Harborough, it's just not visible.
You can see it between the black line and the mid-blue one as it crosses the point.
You might be able to, Mr. Blunt.
I
need your glasses.
Yes, unfortunately, it mirrors one of the other lines.
Yeah, and I'll check the dementia point. I mean, I'm sure there is absolute expectation that there will be similar levels of dementia incidents across the county.
Mrs. Wright.
Thank you. It's just a question really regarding page 43, point 20, and it's just a question: how far are we along looking or exploring the possibilities of development of a company and also becoming a registered social landlord, or are we not exploring that anymore?
So I think there is a report due to be presented to Cabinet later this month, which talks about the potential or the opportunity and the option of the council doing that, but certainly no decisions have been made in that regard. It is one option, and it would provide the things that I mentioned in there. It would enable the council to be a registered social landlord, for example. It would enable the council to hold tenancies, but certainly no decisions have been taken in that regard.
I suppose I'll ask the obvious follow-up question. Would it not then be the point to actually include it as part of this paper, as an addendum to that agenda, to that point on the report? Well, if something's going to Cabinet which relates to that company, might it have been better to include it as part of this paper for this committee to scrutinise as part of this agenda item?
I think the discussions around whether or not the council would want at some point in the future to form a housing company would be a much wider discussion than certainly social care. It would have much far-reaching implications. It would just be a benefit to this social care development potentially, but it is in itself a much bigger piece of work which wouldn't become part of this committee's remit or responsibility.
Right, there's no further questions. I think we'll note the report. And again, I think I think the fact there's not many questions is a positive, because we've looked at this idea before, and I think the committee has been fully supportive of wanting to move into this area, because anything we can do to mitigate care costs going forward is something I think they're strongly welcome. I think it would be worth minuting that if members are happy. We're totally happy with the way forward that this council is looking at. I know it's not asked that, but I think it's worth noting for Cabinet that there is support here for that. So now we're going to move to agenda item 14, which is the review of long-term residential and nursing care fees, which is pages 111 to 118. And John's not pointing in any direction, so it must be John.
Brief introduction, Chair. So, the committee's last meeting, committee received a report on the update of the stage 1 of the consultation around establishing new fees for residential and nursing care, along with proposals for stage 2. And Sandy is now going to provide the committee with an update on the outcome of the stage 2 consultation and the proposals which will be presented to Cabinet.
Thank you, Chair. As John said, this was a two-stage consultation. So the first stage dealt with the general architecture of how we pay fees, and the second stage dealt with the detail of the actual fee rates and the approach to implementing the new arrangements. I'd emphasise that this consultation is actually about how the council will invest more in paying for care in care homes. Many of the consultations which take place are not about the council spending more and increasing its investment. This is very much what this report's about, and this consultation was about. So the committee, as I received a report in March, which was before the start of the second stage of consultation, which really outlined the proposals that were going to be consulted on. So I won't go through those in detail, because those have already been to the committee and discussed. In terms of the response to the consultation, there was a relatively low level of responses. So there were a number of ways in which consultees could respond. So there was an online questionnaire that could be completed, and there were a series of meetings which took place with providers across the county. And there was also a meeting with the general public. But I think we were a bit surprised at the relatively low number of responses that were received during this phase. The report outlines the feedback received during the consultation and the key themes which emerged from that, and those are outlined in paragraphs 20 to 24 of the report. And a report will be going with final recommendations for a decision to Cabinet on the 25th of June.
Do I have any questions from members at all? Mrs. Wright.
Just what I'm just interested to know if what percentage, if any, of service users will see a reduction in third-party top-ups.
Thank you, Chair. I can't give you a precise number, but around about 20% of older people, there's very few working age adults, but older people will have some kind of third-party top-up. And the size of third-party top-ups varies greatly. So a third-party top-up can be anything from a few pounds a week to several £100 a week. So the difference will be, if it's a small contribution, the council's increase in fees are likely to wipe out the third-party contribution altogether. But if it's a much larger top-up that's being paid, it will just reduce it. It wouldn't stop it. But I mean, the great majority of third-party top-ups should be reduced, and the majority we're expecting that the majority will be replaced by the increase in the council's fee.
Thank you for that. I think committee work was this. I know from the chairman's briefing at the start that this is a substantial additional benefit. A substantial additional input of money into this service from the county council at a time when we know it's financially difficult, which I think we as a committee welcome. It certainly brings the fees up substantially and may have the impact of not having the unintentional consequences that service providers have long associated with how they charge people funding their own services. So I think we welcome the report, and it shows the commitment, I believe, of this council to supporting the people that need the service. And again, I think sometimes we perhaps need to sound that out a bit more in these reports to show that we do care, we do try, we do look into it seriously, and we do the work and research behind getting it. So could I thank everybody involved on behalf of this committee for the work they put into this, and share your disappointment that we didn't get as many people joining the consultation as we all would have liked, but it's always the way, unfortunately. So thank you to that. So we now move on to agenda item 15, which is the provision of services, which is pages 119 to 132. And in inimitable style, I'm sure it'll be an introduction from John, followed by detail from Peter.
Thank you, Chair. So this is a report on how the adult social care services are meeting needs within the county. It's a report that was requested by the committee, and we've tried to provide some detail on the sorts of volumes and demand and numbers and the processes and the waiting times, but I'll let Peter go into the detail of that. What we can't provide is information on unmet need, and we simply can't provide it because we don't collect it. So it's one of those things that's not known. There are various organisations who undertake to try to come up with a number at a national level, and some of those are mentioned in the report, but certainly at a local authority level, local authorities don't collect that information, so it's not something that's easy to provide, but what we can tell you is about the need that we do meet. So Peter's going to do that now.
Thank you, Chair. And John. So Scrutiny want to see what assurances the Department can provide about the levels of unmet need at a time when we recently restructured back in 2017, have continued to deliver on our MTFS saving requirements, and yet when the funding crisis facing adult social care is at a focal point of considerable national and media interest nationally, and yet Leicestershire County Council continues to to be the most underfunded county council in England for adult social care. Paragraph 14 of the report sets out the processes by which care needs are assessed and met. Urgent and high-risk cases are always prioritised, and that's a key message to Scrutiny. We have a strategic partner assisting the department with reviewing how long the initial request to assessment to service delivery process is taking, with a review to reducing this length of wait. Paragraph 17, page 121, describes how eligible service users' needs can be met. Allocated personal budgets can be taken with a direct payment, or service users can ask the council to arrange services through managed services procured via contracted providers. Paragraph 19 describes the range of in-house provision available to meet these needs, and again, the quality around that in-house provision is generally very high, as rated by external Vigilance CQC. Direct payments reached a peak in 2017, hitting nearly 2,500, but this is now a reducing figure, and a slight reduction in direct payments reflects that service users are more settled post the Help to Live at Home changes. Page 122 sets out the detail around waits for packages of care with the external dom care market, which is an improving picture, and paragraph 27 details the key pressure points being mainly at the Harbour and Melton areas. In terms of quality, page 123, the key headline there is that generally Leicestershire nursing and residential placement market is of good provision, with 77% of our offer rated as good by the CQC. Page 123 highlights paragraph 31 that there is very little research undertaken about the notion of unmet need, as John highlighted in the opening statements. Reference is made to the Ipso Mori Unmet Need Final Report in 2017 and also to the King's Fund report, Key Challenges Facing Adult Social Care in England. These papers reflect the debate about relative and absolute levels of unmet need and how this can be measured. Paragraph 35 looks at workforce pressures across the whole of the social care economy, and then the target specifically focusing on our department, the vacancy rate stands at 7.5%. Vacancy rate for roles within adult social care, but we have various initiatives to address that, such as the Step Into Social Work programme, and also in recent months we've considerably reduced the spend on agency social work. The resource implications section of the report discusses the various realities facing the Directorate and reflects at paragraph 40 the more realistic perspective of activity given current funding streams, resulting more recently in a reduced and reducing number of service users receiving care services. Going forward, the target operating work will address issues around timeliness of assessment, reducing delays, delivering eligible care and tackling variability in social care practice across the county. So in conclusion, we would suggest that there does not appear to be relatively high levels of unmet need across the county. Performance is generally positive across key metrics, with the exception of service users and carers' experience as evidenced in annual surveys. But work has started to refresh the department target operating model and strategy, and there will be a focus on improving performance and even better use of resources to meet eligible assessed need.
Thank you, Peter. Do members have any questions? Because if not, I'll kick off. Page 122, para 26. What action plan have we got in place for the poor residents of Harbour and Melton?
The data from Harbour and Melton from the care pathway perspective is fed into our commissioners, and they address that in terms of developing the market. In relation to meeting specific needs on a day-to-day basis, if the frameworks can't meet that need, a direct payment will be provided to service users, and we will support them to employ, to get other provision off the framework if possible.
So is what underlies that response is that there's potentially in those areas more provision in the private market, and therefore for members paying for service users paying for it themselves is the way forward to get the care they require.
I think I wouldn't say there was more provision in the private market. In fact, there's probably less provision, and that's the problem. So there are hotspots within the county, and we've got the map there at the end of the report, which shows in pink, bright pink, I think it is. Those areas where it is hardest to commission domiciliary care services. And that's because of the rurality issues. It's because there are fewer people prepared to travel and work in those locations. Those providers that are responsible for those areas often are paying well above national minimum wage and well above national living wage, actually. But still they find it difficult to recruit, and partly that's because of employment levels. So those areas will not only have they've got all the issues with rurality and transport links, etc., but they also have full employment, and there are fewer people able to take on the roles that we require them to take on. So it is very difficult. What Peter was alluding to is that where our framework providers can't provide a service, we do seek out any other provider that might be available in those areas, and we also offer people a direct payment if they can find alternative ways of providing the service outside of the normal domiciliary care frameworks. We'll obviously be very flexible with people around that. One of the initiatives that we are looking at is working in the Melton area, for example, is a group of local people and local villagers have come together and are seeking to establish a sort of a village enterprise, which would be run and owned and operated by local people for local people, and we're supporting them to do that. It's something that has got quite a lot of development in the southwest, so in Gloucestershire and Somerset, and I think it was highlighted on a recent BBC Panorama programme, the Somerset model, and we're seeking to implement that in the Melton area as a trial, and if that's successful, then obviously we'd roll that back out into Harborough as well.
Mrs. Wright.
Thank you. I think mine's rather a comment rather than a question. So it's about really unknown needs rather than unmet needs, and the correlation to access to information. So if service users are saying it's difficult to get access to information, it's then I'm just concerned that there may be an unknown needs factor out there that people just don't know, because as you said yourself, it's a very complex system and it's people knowing what they're actually entitled to, and I think that sort of pattern follows through into other papers around information and advice services. As I say, I think it's more a comment rather than a question, but a concern.
Mr. Sheehan.
Paragraph 47, page 126, you start off by saying there are strong operational working relationships with health in place, but then you go on to list 4 areas where you've got concerns about the way things are working, and you mention regular meetings with health to address the pressures, etc. But I just wondered where you are in these discussions in relation to the issues you've identified.
In relation to continuing healthcare, I know that their protocol is in the process of being agreed. An escalation and dispute process is part of that protocol, and those discussions are ongoing. Therapy services impacting on service users and lack of capacity in district. That's part of a community services review, which is being led by West CCG, and we have senior management at the table in shaping the design, implementation of that therapy services redesign. So we are contributing, commenting, challenging, and supporting the production of a revised footprint for therapy services. Where's the other patient marketing, healthcare, therapy service? That's it. But there are regular management meetings, and we're contributing to those.
Are you happy with that, Mr. Sheehan, or do you want to come back?
Well, I just wondered if you could explain what we're doing about the lack of capacity in district nursing provision. I mean, that's on their side, surely.
So I think there's a report on the community services redesign programme that, as Peter mentioned, is being enacted by the clinical commissioning groups together with the Leicestershire Partnership Trust. They're looking at the whole of the community health service provision, and they're reviewing that and seeking to redesign it. A report on that came to the Health Overview and Scrutiny Committee earlier this year, and within that report the CCGs identified that there was a lack of capacity in district nursing, in the sense that it is, I forget the percentage, but it's something like 20% lower than the national average or something to that effect. So what they're seeking to do is redesign their current services so that, if you go back to the report that we had on the sustainable health and social care, where we were talking about the development of integrated locality teams and the development of a home first service. At the moment, the community health services have a single service that they call the integrated community services, so the ICS service. They're seeking to take that service, identify which elements need to be in the home first element, the bit that steps you down from hospital, or the bit that stops you going into hospital, and that's largely the therapy services, and separate that from the district nursing services, and the district nursing services will be then based around the integrated locality teams. So they'll be the services that are working to keep people at home and to provide people with the maintenance health care, working closely with the GPs around the new primary care networks. So that's the process that our health colleagues are going through, and obviously we're supporting them in that, because we want to provide an integrated offer with social care. So we're supporting them to do that. They think that they can release some capacity through doing that. So quite a lot of the district nurses, for example, are currently tied up in providing people with a step down from hospital services, when in fact what we want them to do is the maintenance at home.
So overall, you feel you're making progress?
We are definitely making progress. If you ask me the other question, which is would I like to see more investment in district nursing and therapy services, the answer would also be yes.
Mrs. Fryer. Mr. Parton.
I've got a question about page 124 with the talking about the workforce pressures again at point number 36, where it talks about key staffing pressures in the Heart in-house specialist home care and in the AMHP service, which is a specialist mental health offer. How short are you to be able to cover the demand for the mental health, and what you're having to do at the moment? I mean, while I was in the queue, I looked on the job website and I can see a job for the county council doing that role here, and it does talk about you don't need experience in a MHP, but you have to be willing to retrain. It's one of the reasons that the staff aren't willing to sort of take on that further experience, and then because of that, there's just a shortage of people to do that specialist line of work.
Focusing on the AMP service, there's a national shortage of qualified mental health professionals who undertake mental health assessments with clinicians at the point of intervention, looking at mental health. Sometimes, obviously, patients sometimes ending up in on orders and in hospital. So there's a national shortage that's reflected locally. The steps we've taken are we have gone out repeatedly to recruitment. We've changed rotas to relieve the pressure on staff, and we have a paper in the offing for a market premier to look to see if we can address the recruitment issues locally. Is there something locally we can do? Is it about the pay? Is it about the location, etc.? Because we believe that we can make it an attractive place, offer an attractive role, an attractive place to work. So we do have actions in place to address that. But I think there's a national shortage of qualified AMPs, and that has to be considered.
A difficult question to ask, but how comfortable are we that the demand is being currently met if there's a shortage? I mean, I'm not said that could be nationwide, but do you think there are people that aren't currently receiving help, or if they are receiving help, they're receiving it at a slower rate than we would have hoped?
So the AMP service, as Peter said, is essentially the main element of the service is to assess people under the Mental Health Act for a potential admission to hospital. There are other pieces of work, the tribunal work, when people appeal against detention. There's follow-up work, aftercare work that's also undertaken by the AMPs. We know that we are currently meeting our statutory requirements around assessment, because there are set timescales within which people have to be assessed when a referral comes in, and we meet all of those. There is no suggestion that we're not continuing to meet our further requirements around tribunals and advocating for people or providing social circumstance reports for individuals that require that. So we are meeting that. We do that partly through the AMPs that we have, the permanent AMP establishment that we have. We also have a significant level of agency AMP. And that agency work is essentially keeping us afloat. We would prefer not to have to rely on agency. We would prefer to have a fuller establishment. we're not unique in that position, but we are significantly depleted. So we've been to recruitment on a number of occasions, 3 or 4 occasions. We haven't managed to recruit an approved mental health professional. We do train our own staff, and we have training courses that commence every single year. So we are seeking to continue to recruit our internal staff where that's possible, but the requirement to become an AMP, you have to be a qualified social worker, you have to have undertaken post-qualification experience, you then have to undertake a post-qualification course, and then to be approved, and then you have to practice, so you're talking about if you think about starting out from undertaking your initial social work qualification, you're talking 10 years before you could become an AMP. So it's a significant undertaking, and it's a very demanding role. It's not the sort of role that everybody wants to undertake, and it's a role that, as Peter said, we have identified that there are other authorities who are remunerating people at a different level. So we are seeking to work with our colleagues in people services to look at that and to see whether or not we can make the offer more attractive.
Right, no further questions on that report. So thank you for that, Peter, again. And it's good to see that we've had a good debate on a paper that this committee has asked for, which I think has, whilst not answered all the questions, has given us a flavour and feel for what we know and what we think we don't know. And I'm sure we'll keep this one under review going forward. We're now on to the final agenda item today, which is agenda item 16, which is provisional performance report, which is pages 133 to 148. And I kept it lengthy to obviously give time to leap to the table. So I don't know whether Matt's going straight in. So over to you, Matt.
Thank you, Chair. Good afternoon, everybody. So yes, this is the report on page 133 of your pack. And it's a summary of the 2018-19 performance in adult social care and heritage and communities. Just a couple of points to note to begin with. Firstly, these figures are provisional at this stage. They've been collated and passed through to the national body, the NHS Digital, who collate them. However, we don't expect there to be any notable changes when the final figures are produced. And they will be published by NHS Digital in the autumn, and a paper will be brought back to Scrutiny, benchmarking us against the national picture and other similar shire authorities. So with that in mind, looking at performance in 18-19, overall there were 28 metrics that were RAG rated during the year, and of these 22 or 79% were classed as green, meaning that they were either meeting or surpassing the target. For the remainder, the target was missed in varying degrees. Areas of good performance during the year include reablement services. Firstly, 84% of people benefited from the service, had no need for further long-term needs services following that. And secondly, 88% of people discharged from hospital to reablement services were still living at home 91 days later. Both of these are national framework metrics. For delayed transfers of care, the report notes that those that were attributable to adult social care during 18-19 were, on average per month, 94 days. Now this is exactly half the amount that was seen during 2017-18 at 188. In addition, the number of admissions to permanent care was within the maximum level set out at the start of the year, and this was the case for both working age adults and for older adults. Moving on to communities and wellbeing services, we see that the number of visits to heritage sites increased on the previous year, whilst library performance held up despite the temporary closures for smart adaptations. We can also see in the report that volunteering also showed a small increase. As noted in the conclusion of the report, the key area for improvement certainly lies in the area of feedback from service users and carers. The ease of finding information and the levels of social contact are two areas highlighted in the report. Neither improved from previous years and both remain below the national average. A performance clinic has been established to oversee survey results within the Adults and Communities Department, and this was started early in the year. Now, since then, in-depth quantitative analysis and one-to-one interviews have taken place. This has resulted in a wide-ranging action plan that has been developed to oversee improvement. In addition to this, we will be repeating a local version of the carers survey this coming autumn. Looking forward, targets and milestones have now been updated, and reporting for 2019-20 will commence this month. Welcome any questions or comments from the committee.
Mr. Parton.
For clarification, what are the margins of error? For example, where, let's say, for example, safeguarding inquiries 1% increase. I mean, there might be a 1% decrease next year. To what extent are you expecting volunteering a slight increase? Or what point does it become statistically for these valid to say there is an upward trend, or that's just within statistical norms?
At this stage, the majority of the reporting we do outside of survey work, which certainly does take into account statistical differences, most of it is just very high level. We look at the general direction of travel. If it's just a 1%, clearly it's a very small change which could happen in reverse the following year, so just bear that in mind. But for survey work, everything's within a plus or minus 5% error rate. We'll take that into account.
Just a quick one from me then, if I might as well. I always like to ask a daft question at the end. Heritage visits. Do we actually take any information as to where the people who visit the heritage sites come from? I'm only thinking of demographically, we've got large parts of the county which have no heritage sites or access to heritage sites. So if the people going to the heritage sites only come from a small radius, it means there's a huge part of our population who aren't using any of our heritage assets because they have no local access to them. So have we looked at that, and are we factored that into there where we should provide heritage access, and what those assets might be in those locations that currently don't have any?
That's a very good question. I feel sure that we do. I would have to check with my colleagues in terms of what we could present back, or what sort of detail we could give you. I mean, certainly I know that we have done work around places like Bosworth to find out what the sphere of influence is and how many people are local, because obviously it has a national presence as well. But I'd have to check with colleagues just to see exactly what information is regularly or routinely collected, and what that tells us.
Mrs. Fryer.
It is a difficult one to find out where people come from, and sometimes I know from my own experience in a district, we found that we were planning a new sort of scheme of things coming into a heritage site. And one of the things how we found out where everybody was coming from, we had to review the parking system. So we did a parking survey, which was nothing to do with planning or health. It was to know that. So it's quite interesting the amount of information you get talking to other partners who may not have anything basically do it, but something quite mundane, and we discovered they were coming from all over the place and for different reasons. It might be something we should look at. We've got 3 very good universities in the county. Is anybody doing a postgraduate course, or is anybody doing something like that would like to build it into one of their schemes? I think this is where you find out what is going on, is to utilise other bodies. And it's quite surprising what the university students and the postgrads are actually doing research into. And that might be something where we could find out a bit more information on the heritage site, say, for Leicestershire, and how to improve them. Thank you. It wasn't really a question, was it? Sorry about that.
We'll await your response with interest, John. As you're almost certain that it is done. It was only really to make our heritage as accessible to our whole population as possible. I mean, I have a division where we don't have anything nearby, there's nothing in it, and it's a bit of a You know, so a lot of the residents of my division will go into Leicester for things rather than perhaps use our own assets in Leicestershire. And I just wonder if there's any opportunity for making things more accessible across the whole of the county as opposed to in certain areas. It's only a thought. Anyway, with that, we'll leave it to another day unless anyone's got any final questions. You have the dates of the future meetings. The next one is on the 2nd of September. All meetings will be held at 2:30. Today's was an exception because we had the presentation beforehand. Sorry? 2 o'clock. Did I say something? Oh, that's right. I meant 2 o'clock. Good spot, Christine. I never expect anything less. So thank you very much for coming today and your participation. I declare the meeting closed.